Good evening. I'm Addie Gasper, nurse practitioner at UW Health Neurology Clinic, and it's my honor to introduce you to Dr. Catherine Gallagher. She is a movement disorder neurologist that works at UW Health as well as the VA hospital. So without further ado, I will let Dr. Gallagher start her speaking on what's new in Parkinson's research.
So, can everyone hear me? No, the people in the back can't hear me. I'll try over here. Yeah, okay. So, I am a neurologist, and I do research using brain imaging, but I don't do molecular biology. And you were supposed to have this lecture from Dr. Corinna Berger, who does do molecular biology. So it's going to be maybe a little bit different than what you would have thought. And there, I pushed the wrong button. So my disclosures are that I work, my research is funded by the Department of Veterans Affairs, which gives me grants to study MRI and PET scans as a way of measuring Parkinson's disease. But I also collaborate with the Alzheimer's Disease Research Center and the Weissman Center, and they get funding from a lot of different areas, but a lot of it is federal funding, some of it's private funding. So most of you are aware who come to this lecture, but just to remind those of you who don't know about Parkinson's disease, that it's the second most common neurodegenerative disease, meaning that it basically causes a part of the nervous system to deteriorate for reasons that are not completely understood. And the main symptoms by which we diagnose Parkinson's disease are the movement symptoms, which are typically early on tremors and slowing of movement, and later on become more gait and balance problems. And the disease is also marked by a number of non-motor symptoms. So there are problems with sleep, and those would consist of the most characteristic ones are the REM behavior disorder, so the tendency to act out one's dreams. Also the sleep apnea, so tendency to have pauses in breathing and reduced oxygen during breathing, during sleep, is common in Parkinson's disease. And cognitive and emotional changes, and some of the moving forward lectures are going to talk to you about some of those types of problems. Then problems with the autonomic nervous system, or the automatic part of the body, the nervous system that maintains the heart rate and the blood pressure and sexual function and some other things that we don't really actively think about. Those functions can also be affected by Parkinson's disease. So we know there's a lot of variability in how the disease expresses itself between patients. So some patients have mostly just difficulty walking and slowness, but they don't have very much tremor. Other patients, the most characteristic form begins with a very particular pill-rolling tremor on one side of the body that then can affect eventually other parts of the body. So the disease is different between different Parkinson's patients. And the other thing is that it progresses at a different rate between different Parkinson's patients. And that makes it more difficult to study. So if we want to give a new medication to see if it helps people with Parkinson's over the people who did not receive the medication, we have to have fairly large samples of participants in those types of studies because there's variability in how the disease expresses itself and how quickly it progresses. So we might have to run a study that we would have to study people for 20 years or 30 years to really tell if there's a difference between the people who got the treatment and the people who didn't get the treatment. And as a result of that, there's been a lot of interest in developing what are called biomarkers, which are biological measurements that can be taken that might predict how a person's disease is destined to progress. Because if we can tell a difference between one group, their biomarker, and between a treated group and an untreated group, well, maybe that means that down the road, 20 years down the road, that treated group would still be doing better than the untreated group. But there can be a lot of problems with whether or not those biomarkers actually predict accurately what is going to happen with the patients. So these are some of the problems that come up when trying to study a very slowly progressive condition like Parkinson's disease, in which there is variability. So what do we know as a fact about Parkinson's disease? Well, we know, of course, that there's a loss of dopamine in the brain. And this is a cross-section at the very bottom of the brain stem. And this is kind of the bridge between the brain and the body. And here is the cerebral peduncle, which carries a lot of those long tracts that connect the brain to the body. And in the cerebral peduncle, there's this area called the substantia nigra. So this is made up of cells that contain dopamine. And we know that in the Parkinson's brain, those dopamine cells are gone. They die off. And why did they die off? Well, we have a lot of ideas about why they die off, but do we know the entire story of what starts this process? Probably not. So when those cells die, they lose their connections. So on this picture, and this was from Corinna Berger, who found it in a graduate student thesis, there's a schematic showing the substantia nigra here, and that substantia nigra sends some long connections to an area of the brain called the striatum. The striatum is the blue and green area here. It's deep in the brain, but it's very connected with all different parts of the brain. And so this signal is showing the dopamine transmitter arriving in the striatum. And in Parkinson's disease, that is lost. And that's, we know, the reason for the movement symptoms that people experience. So why do those dopamine cells die? Well, we know that Parkinson's disease is a condition in which there's accumulation of abnormal proteins. We're now realizing that there's a family of these, what we call neurodegenerative diseases, which all accumulate different types of abnormal proteins. So the big one would be Alzheimer's disease, and they get a protein accumulation of beta amyloid that makes neurofibrillary tangles in the brain. Now, Parkinson's disease is different. So in Parkinson's disease, there's accumulation of alpha-synuclein. So it's a different protein, a different signature of the disease than we see in Alzheimer's disease, but there's some similarities in the theme. So this protein that normally the body and the brain would clear out and get rid of kind of gets stuck there, and it gets clumped up, and it forms these clumps that can't be dissolved very easily. And so it's like damming up a river, and then we get a bunch of lakes behind it, and then downstream there's damage to those cells, and those cells would eventually die off. So in the lower left panel here, you see a picture, a pathology picture. So this is a slice of the brain, and you may not be able to see really well, but there's these little sort of a teardrop-shaped thing here, and that is one of the brain cells. It's one of the neurons. And then inside of it, there is this pinkish area, and that is the Lewy body, which is a clump of alpha-synuclein that's accumulated in there, and the cell is not able to clean out. So one question is whether those clumps of protein are actually what is doing the damage or not. Is that what's causing the brain to lose its cells and for those cells to die? Or are those clumps actually a little bit protective to the cells and preventing further damage? And as I'll talk later, there have been a lot of experimental therapies to remove those proteins that haven't necessarily worked very well. And it might be because the proteins themselves are not actually the cause of the disease. So in this picture, this is in Alzheimer's disease, the formation of amyloid fibers. And this would be similar for alpha-synuclein. It might not look exactly the same, but this is a schematic diagram. And it forms this clump here. But there's also some little tiny fragments called oligomers. And these are shown over in the left side. And those little oligomers can get into synapses, which are the communication centers between neurons, and they can do other damage. So it might not be actually the clumps that are the problem. It might be the dysregulation of the system that results in these other small fragments floating around that are the problem. So we can measure some of those fragments various ways, and one way would be to look at the spinal fluid. And I'll talk about that a little bit more. So this is pretty dense. This is the picture of the machinery that's supposed to get rid of that alpha-synuclein protein in Parkinson's disease. So normally alpha-synuclein is eaten up by the proteasome, which is this system. So, you know, your body is made up of thousands of millions of cells, and each cell, just like your body, has its own organs and its own system that carries on the processes that it's supposed to do. And so some of the organs in the cell, one is the degradation machinery, and this degradation machinery does a process called autophagy. Autophagy means self-eating, and it's very important for the renewal of cells and proteins in our system that these proteasome is crunching up those abnormal proteins and getting rid of them. And somehow this process is not working well in Parkinson's disease. And the other process that isn't working well is the lysosome. So this is pretty similar to the proteasome. It's a little bit different, but it's another little part of the cell, a little organ that gets rid of abnormal proteins. So what we do know, though, about this system is that there are some families that have carried Parkinson's disease. So there are some families where the disease is inherited, and many people within the family tree will develop Parkinson's disease. And in those cases, those groups may have a problem with their DNA. So in their DNA, and the DNA codes for particular proteins, so the DNA is translated into the proteins that make up the cells and all the machinery in the body. So if there's a defect in the DNA, then that can be passed from one person to another in inheritance. So in these particular families that carry problems in the DNA and have high incidence of Parkinson's disease, there have been a number of those defects that have been discovered and described by scientists. And many of you may actually be aware of some of those defects, but they would be, for example, Parkin, which is somewhere here, glucocerebrosidase, and LRRK2 are some examples of genetic defects that can increase the risk of Parkinson's disease. So knowing about those families, we've been able to study those families and come up with some ideas about how the system isn't working right, because those defects all affect this autophagy process. Now, what else do we know about Parkinson's disease? Well, there's a gentleman named Heiko Brock, who's a neuropathologist from Germany, and he did some studies where he looked at Lewy bodies in the brains of people who died for incidental reasons. Some of them died in car accidents, and some of them died of other natural causes. And then he also compared those brains with the brains of patients who had Parkinson's disease. And he took very standard samples of the brain. He started in the brainstem, which is down at the bottom here, and that's where the substantia nigra is. And then he took sections here, he took sections through the cerebral cortex, and also looked at the smell nerves, the olfactory bulb here on the bottom surface of the brain. And so he took all these standard, or his group took all these standard sections, and then they examined them visually to see if there were any Lewy bodies there. And they developed a system for showing where the Lewy bodies were. And what they found is that the people who had Lewy bodies in the bottom of the brainstem and the olfactory bulb did not have Parkinson's disease, but if they had Lewy bodies in the brainstem, the olfactory bulb, and the substantia nigra, then likely they did have Parkinson's disease. And then if they had Lewy bodies in the brainstem, the olfactory bulb, the substantia nigra, and the cerebral cortex, then they certainly had a Parkinson's disease. So based on this cross-sectional data, so circumstantial observations of people who had died, he developed the theory that Parkinson's probably starts in the bottom of the brainstem and moves up gradually through the rest of the brain, that the Lewy bodies sort of spread like this. And that has also led to what's called the second hit hypothesis, which is that perhaps there is something from the GI tract, from the gut, that then gets up to the brain, the dorsal motor nucleus of the vagus nerve, which is in the lower brainstem. And then a second environmental stimulus comes from the olfactory bulb, and maybe some interaction between those two events triggers this process. So that is a theory at this time. It's not proven. But a lot of diseases, we think there has to be not one thing wrong, but a couple of things that get together in an unfortunate way to cause a disease process to initiate. So that's one of the ideas about it. So shifting gears to talk about Parkinson's research. So I've talked a little about what the recent discoveries have been and what the theory is about how Parkinson's is produced. And we've discussed that there's a protein, alpha-synuclein, and it clumps up in the brain and forms these pink deposits that are called Lewy bodies, and that helps us track the disease. And then the question is, okay, why can't we do anything about this, and why is it taking so long? And, I'm as impatient as you are with this. And unfortunately, it's very, very complicated, and that's part of the problem. So why don't we have effective treatments for it? So a lot of times treatments fail because we don't entirely understand what is causing the disease. We have a clue, we have some ideas, the things I've shown you, but we don't actually know, why one person gets it and another person doesn't get it. So we don't fully understand that, and that limits our ability to really address it with effective therapies. We don't know what initiates the cascade of the abnormal protein accumulation, except we do know there's few genetic defects, but we don't know when it happens out of the blue in somebody who has no family history of Parkinson's, why that would happen. Another reason that it might fail is what I mentioned before, which is we might be using PET scans to follow what happens with our Parkinson's patients. And maybe that PET scan has not been fully validated. So maybe we don't know that loss of signal on the PET scan is truly related to the disease progressing in the person, because the people have a lot of compensations for these things. So these are some of the things that happen. Another thing is that we have a lot of animal models for these diseases, but the animals, a lot of times, like mice or rats, they don't live very long. They don't live as long as humans do. And so we have to manipulate their genetics in order to get them to express something that looks like Parkinson's disease, but we can't really tell it's Parkinson's disease because they're not a human. And so there can be some inaccuracy or some problems with translating what we learned in an animal, which is very valuable, but may not exactly resemble what happens in the human. So there might be trouble getting the treatment that works in an animal system to work in a human. And again, those usually come down to limitations of knowledge. So I wanted to talk a little bit about the types of research that's done. So some of the very ideas that would help us understand why the disease occurs are conducted in laboratories, particularly in universities, and they may be in cellular systems. So for example, stem cells are often used to investigate what happens in the cell in Parkinson's disease. There are observational studies. So we look at a bunch of people who have Parkinson's disease or who have risk factors for Parkinson's disease, and we try to figure out, can we predict who's going to get the disease, or can we predict how their disease is going to go, or can we help develop biomarkers that predict that accurately? And then once we actually have treatments that might be effective, those go into clinical trials. And then after the clinical trials are done, and even after treatments are approved, there are registries where we follow, for example, if a whole bunch of epilepsy patients are taking a certain medication, are there adverse events after the drug is approved? So the clinical trials, so usually the basic research in universities leads to candidate new therapies. Then those treatments are tested in laboratory systems and laboratory animals. And then if they look promising, a lot of times they'll be adopted by pharmaceutical companies or potentially by the government, by NIH trials. And they will be pushed through a very systematic evaluation to determine if they actually are helpful to patients or not. So those studies, the phase 1 studies, are oftentimes just seeing if the treatment is safe. And the FDA can be very particular about this. And even if you have something that's tolerated by patients with leukemia, they may not feel it's clear that it's tolerated by people who have Parkinson's. And so it may need to go still through phase 1 study to show that it's safe for people to take. Then the phase 2 trials look at larger groups of patients to determine if there's likelihood that the treatment will be effective. And these studies may have something like 50 to 100 people in them, depending on the treatment. And then the phase 3 studies are randomized clinical trials. And so some of you may have had the opportunity to participate in clinical trials. I've had the opportunity to participate in clinical trials. So usually clinical trials are very large studies where we try to wash out any bias. And there are a lot of potential biases in research by where you get your population from. If I go and recruit a lot of patients from Madison, Wisconsin, who are Caucasian and very educated, then those people, the results of a study I do with that population might not translate to a different population. And so the goal of randomized clinical trials is to be generalizable, so that once we find out something that works in a population in China, it would still work in a population in the United States. And so there's very strict rules about how participants in these studies are randomized. There has to be a system for having some people take the active drug and some people take the control treatment, where the people who are receiving it don't know what they're receiving, and the investigators who are evaluating them may not know what they're receiving either. So it's very stringent towards avoiding getting the wrong results. And then if a result looks halfway through the study like it's going to be harmful, the trial has to be halted. And if it might even be that if it looks like it's not going to meet its primary endpoints, or it's not going to be effective, and enough people have enrolled, it might have to be halted then too, especially if it's a risky treatment. So they're very carefully done, these clinical trials, and they're very expensive. Then, once a treatment seems to have weathered that process and have benefit after going through clinical trials, then the FDA approval is sought, which is also a very fastidious process. And then ultimately, after approval, the treatments may continue to be monitored through phase 4 evaluations. So one important things to understand about clinical trials is that participation is entirely voluntary, so you can sign up for them or not sign up for them. It should have no bearing on your health care or how your doctors view you or anything like that. If you enroll in a trial, you may receive an active treatment, or you may receive a placebo treatment. Means you might get a sugar pill. And the reason for that is that there's a very large effect of sugar pills. So placebos have been shown in many studies to have as high as a 30% benefit. So we need that the active treatment does better than 30% improvement a lot of times in order for it to really be better than placebo. So you might be receiving the placebo even if you are in the trial, and you can stop being in the trial at any time. If you sign up for a trial, you have no obligation to continue or finish it. And the other thing to realize is that because these are often experimental treatments, there may be no benefit to you directly. And so you shouldn't count on that it's going to cure your disease or make you better. Hopefully, if it's a new treatment that has a lot of promise, it will, but many of these trials have not ultimately panned out to be effective. So if you wanted to get information about clinical trials, the NIH website has a lot of information. There's a site called clinicaltrials.gov where all the clinical trials are required to be registered. And if you're interested in looking for a trial to participate in there, you can go in clinicaltrials.gov and you can type in Parkinson's disease, and you'll get a list of all the trials that are going on in the United States and even in Europe, looking at Parkinson's disease and whether they're active treatment trials or observational trials. And you can see the contact information for those research coordinators, and you can call those sites and become involved if you so desire. Michael J. Fox Foundation, as you know, probably a lot of you know, also has a lot of information about current research developments in Parkinson's disease, and has an application called Fox Trial Finder that is a similar search engine for looking for trials. Movement Disorder Society doesn't have a trial index, but it does have a lot of information. And of course, the American Parkinson's Disease Association and the Parkinson's Foundation are also good sources of information. So looking at Parkinson's disease, many things have been tried, and if you ask me about a particular treatment, I might recognize it and I might not. But I think that there are some important pieces of information that have come out in recent years about Parkinson's disease and some important potential treatments. So first I wanted to talk about the prion hypothesis. So one of the hypotheses that's come out is that these proteins that form the clumps in the brain and seem to cause part of the problem might actually be able to spread between cells in the brain. And while that sounds really scary, this process is very, very slow, and we think that that sort of thing might actually be going on in a number of the diseases, including Alzheimer's disease. Also, the interest in what's happening in the gut, the GI tract in Parkinson's disease, what role does it play in the disorder? Then I wanted to talk a little bit about some of the ongoing observational studies and some biomarker development, and then the recognition of inflammation as a contributor to many of the neurodegenerative diseases, including Parkinson's disease. So this is unfortunately a little small, but this is a study that was published by Cordova et al. And these were the brains of patients with Parkinson's disease who were treated with fetal cell transplants. This was going on in the late 80s, early 90s. They had donated dopaminergic neurons from the brains of fetuses that were transplanted into the striatum, into the part of the brain that loses dopamine in Parkinson's disease patients. And some of those patients have been followed out for a really long time, and so several of them died, and they looked at their brains with autopsy. And when they did this, they found that there were some of these brown spots, some of these Lewy bodies and synuclein inclusions inside the cells that had been transplanted into those brains, especially the ones that had been in there a long time. So this one you can't read here, but it says 14 years and 4 years and 18 months. So the ones that were 18 months old didn't have any synuclein inclusions. The ones that were 4 years old were getting them, and the ones that were 14 years did have the Lewy bodies within cells of the transplanted neurons. So that suggests that the dysregulation in the brain that's causing these protein clumps in Parkinson's disease is something that can affect cells that are transplanted into that brain, which supported or started off a little bit about the prion hypothesis that maybe these abnormal proteins in there are somehow affecting some of the normal cell proteins to also turn into these clumps. So scary as that may be, it's very slow, very, very slow process, and but it's an advance in the field. So another understanding that's started to come out in the past few years is how the GI tract, the gut, is associated with Parkinson's disease. So I mentioned that the dorsal motor nucleus of the vagus is a part of the bottom of the brain stem, that often has Lewy bodies in it in Parkinson's disease. And that is connected with nerves to some nerves that control the movement of the gut. So we also know that we can see in patients who have Parkinson's disease some of the synuclein clumps down in those nerves around the gut. So this information started to make people think, or researchers think, that perhaps some of this process might start in the gut rather than in the brain. So Some other things that were observed is that if you cut the vagus nerve, so if you cut that nerve that goes between the gut and the brain, which was done in a few patients for various medical reasons, that then there was a slightly reduced risk of Parkinson's disease. And then there was a hypothesis that the appendix, that some of the synuclein inclusions might begin in the appendix. And so there was a very large study in Sweden of patients who'd had their appendix out to see if that modified the incidence of Parkinson's disease. And they actually found that there was a higher risk of Parkinson's disease in those who had had the appendix out, but it's a very small difference. So it was 0.19 per 1,000 versus 0.15 per 1,000. So question of whether this is actually, how much of an effect this is. And the other thing, of course, that we've observed is that constipation or problems with movement of the gut can long precede, or a few years anyway, precede the diagnosis of Parkinson's disease. So the thought is that these nerves in the gut starting to get the synuclein accumulations in them, which later move to the brain, which later cause symptoms, neurological symptoms of the disease. So this was work by Dr. Kathleen Shannon, who's the chair of our department, and a number of her collaborators at Rush University. And they actually looked at colon tissue from patients who had Parkinson's disease. They had 23 older control subjects that were age-matched to their Parkinson's patients, and 3 Parkinson's patients from which they got, who had had colonoscopies in years before, at least 3 years before, and had a biopsy of one of their polyps. And then they stained for synuclein in those colon biopsies, and they found that the patients who had Parkinson's, which are the case 1, 2, 3 here, had those synuclein inclusions in their polyps, whereas none of the healthy controls had them. So that suggested that perhaps the inclusions in the gut wall were occurring before the patients developed Parkinson's disease. So now to skip on to how are we looking at the natural history disease and the development of more accurate biomarkers. So this is a slide from the Parkinson's Progression Markers Initiative, which is a consortium of researchers who recruit Parkinson's patients and follow them longitudinally every few years with brain imaging, cognitive testing, a number of other evaluations. So I signed on to this database, and this database is a researcher available, public. I was speaking so loudly that it died on me. So anyway, this PPMI database has recruited 600 patients from age 60 to 79, 280 participants from 70 to 79, and 38 participants who are in their 80s. And it has some people who have genetic risk factors for Parkinson's disease, as I was mentioning, like the GBA gene and the LRRK2 gene. And then it has a number of what they call prodromal patients. So they've identified people who do not have Parkinson's disease, but do have REM sleep behavior disorder, constipation, loss of sense of smell, other features that would predispose them to developing Parkinson's disease. And they are following that prodromal cohort year by year by year. So this very large, and you can apply to use this data and study this data, although of course the investigators who are running this study get to approve whether you can use it for your research. But it's a very large database that is tracking the natural history of the disease and the natural history of the prodromal symptoms and trying to develop better biomarkers like MRI scans to make the diagnosis earlier and to tell with all this heterogeneity where how we expect the disease to progress. And this is one of the studies by Postuma et al., where their group was trying to determine if they could predict in patients who have REM behavior disorder who will develop Parkinson's disease. So they have this is called a survival curve, and this is they start out with nobody having Parkinson's. As they go along to 2 years, maybe 20% develop Parkinson's, 4 years, maybe 40%. So, and they get down to 10 years, and there's only 20% who've not developed Parkinson's disease of the people who have this very characteristic tendency to act out their dreams. And if they combine it with other features that are suggestive of Parkinson's disease, like loss of sense of smell or subtle changes in walking or movement, then they even get this survival curve to come down lower and the risk of Parkinson's disease to be higher. So it's not very comforting to you, those of you who have Parkinson's disease, but one of the problems is that we probably need to treat, if we find an effective treatment, we need to treat the disease as soon as we possibly can. And so if we can identify these people who are destined to develop it, we're hoping that the interventions would be most effective in that group. So I've participated a little bit in the biomarker research, and this was some PET scans of patients with Parkinson's disease. So this was an analog, actually, of levodopa, which is turned into dopamine in the brain, and it's got a radioactive tag on it. So if I give it to patient IV, it will go into the striatum, those central areas in the brain that have the dopamine projections from the substantia nigra. And one thing that we did notice in this study is that if we tracked different parts of the striatum, the caudate nucleus, the putamen on either side, so the side opposite the part of the body that shows symptoms of Parkinson's disease, the brain opposite that, is usually the most affected area. And the patient may not even show symptoms on the other side of the body at the time that this scan is taken. But what we do see is if we track in all those different regions the loss of the tracer activity, it's pretty parallel. So here's the normal ones on the left side, and here's the Parkinson's disease on the right side. So even though these people may only have symptoms on one side of the body, they're losing this dopamine on both sides of the brain, suggesting that this process is fairly generalized even before we see the movement symptoms on both sides of the brain. And another effort towards biomarkers, these are some of my esteemed colleagues, Brad Christian and Sterling Johnson, and they study Alzheimer's disease. And so these are also PET scans. They're positron emission tomography. So we give the person an injection of this radioactive tracer molecule, and it goes specifically to those, in this case, to those protein inclusions. So in Alzheimer's disease, there are neurofibrillary tangles, and there's also tau, which is another protein that gets deposited into kind of bundles of sticks in the brain. And so we have a tracer for each one of those, and if we inject that tracer into the blood, then it will be targeted into the brain, and we can actually measure how much of that abnormal protein is in the brain. So These images were of people who have the protein uptake of Alzheimer's disease. So unfortunately, we don't have a tracer like that for the Lewy bodies for Parkinson's disease. We don't have one of these that we can inject. We can show the dopamine loss, but we can't show those abnormal protein globs in Parkinson's disease. But Michael J. Fox Foundation and others are sponsoring studies to try to come up with a synuclein tracer that would do a similar thing for Parkinson's, and thus we would be able to follow whether or not we are able to change these proteins. So interestingly, in Alzheimer's disease, there have actually been some trials of vaccines that have been successful in changing the amount of this activity that's seen in a given individual from one time to another. But unfortunately, those vaccine studies did not meet their primary endpoint of actually making the patients better. So those have been, at least so far, put on the shelf and are not probably going to be FDA approved for treatment of Alzheimer's disease. But it just shows you how difficult the whole thing is. The other thing that we know about Parkinson's disease and Alzheimer's disease is that there's inflammation. So it seems like the part of the body that fights off attacking germs and things like that normally we develop an inflammatory reaction. So if you get a cut on your skin, you'll develop a pus in there, and you'll get red and inflamed. So that's a normal reaction. But in the brain, there's some cells that mediate inflammation. They're called the microglia. And it seems like the microglia, those inflammatory cells, are overactive in these neurodegenerative diseases. We have a lot of evidence of that. We know that if we give anti-inflammatories, that the risk of Alzheimer's disease might be lower. And this is another PET scan study. So again, an injection was given to the person that then targeted these particular cells in the brain and marked the microglia. And there's increased microglia activity in Parkinson's disease compared with normal. So something is going on with inflammation in the brain in these conditions as well. So I'm actually going to skip that. Another type of biomarker is from spinal fluid. And I don't know if anybody's ever had a spinal tap, but a lot of the biomarkers that have been validated for Alzheimer's disease are actually proteins that are measured in the spinal fluid. And when the degenerative process starts, a lot of times the spinal fluid proteins are high, but then when the person develops symptoms and the proteins start going into the brain, the spinal fluid levels get lower. And so this is something that's been used to track the progression of Alzheimer's disease. And it's also being developed for Parkinson's disease. We can measure synuclein in the spinal fluid. It's not a diagnostic laboratory test at this time, but it's being developed as a way of following how bad the disease is. So to talk about just a few ongoing clinical trials based on those ideas that I've presented. So we have some studies that are looking at whether we can speed up the removal of the alpha-synuclein protein. Now, just like with the Alzheimer's case, we don't know if that'll be an effective treatment or not, but it's the best bet that we got. So there are some vaccines that are being developed and have completed phase 1 trials. There are also some monoclonal antibodies, and these will be injectable forms of a protein that binds to the synuclein and potentially removes it. Then many of you may have heard of this nilotinib, which is a leukemia drug that is approved for use in a particular type of leukemia that has an abnormal chromosome called the Philadelphia chromosome. But anyway, it regulates protein clearance in the body and possibly in the brain as well. And so there are a number of centers that are investigating whether or not nilotinib will work for that. And it's and then there's another one here that's one called Neuropore, which may change the folding of the synuclein protein. So we're going to have a trial of something similar to this. I don't know of us having the others. There are some agents that are being tried in the UK which will modify some of the genetic effects that may be encouraging the accumulation of these proteins. There was a trial called Serogene, sponsored by Michael J. Fox Foundation, I believe, that was for a growth factor that was going to support nerves in the brain and prevent them from dying, but that trial didn't meet its primary endpoint, which was to make the Parkinson's scores, the Unified Parkinsons Disease Rating Scale scores, better in the group that was treated. And so it's not being pursued anymore as far as I know. Same with this isradipine. There's some really unusual things. There's a fecal transplant trial that's going on in Israel. And then there are some stem cell trials, and everybody's always interested in stem cells. So stem cells are just cells from your body that could differentiate into different types of cells. I mean, they could have differentiated into liver or brain or nerves or other cells in the brain, microglia. But researchers have learned how to program them to turn into a specific kind of cell. Now, most of the nationally sponsored stem cell trials are still at the animal stage at this time. So if you hear of somebody suggesting that you should get a stem cell treatment, it's probably not one of these NIH-sponsored ones. Other treatments for the symptoms, there will be a subcutaneous levodopa infusion study. Dr. Dent's heading that up. There's going to be subcutaneous apomorphine. I'm not sure if this is the United States yet. There's istradefylline was just approved. This agent actually acts on some of the same areas that nicotine acts in the brain, but was found to modify the processing of dopamine in the brain, and so is FDA approved, but I haven't seen it being available yet. Everybody always wants to know about cannabis, and I have a slide about that. There's some medicines that are going to be used to help cognition in Parkinson's disease. So for the cognitive treatments, we previously had been able to try the medications that are used in Alzheimer's, which are somewhat effective in some patients. But the problem is they're only modestly effective in Alzheimer's disease as well, so they're not really magical. So there'll be some trials of that, and Dr. Shannon is actually planning one of those. There are some treatments specifically for levodopa-induced dyskinesia. There are many cognitive and motor retraining trials, and there are many trials that have been very supportive of exercise and physical therapy as being beneficial for Parkinson's disease. And a few other sundry things, and I don't think that this is a comprehensive list. There are some new trials for neuromodulation, so stimulating the transcerebellum with direct current at University of Iowa. Some new deep brain stimulation techniques, some magnetic stimulation techniques, and you may have heard of the MRI-guided focused ultrasound as a way of producing focal lesions in the brain for treating the symptoms, and this is actually approved for tremor, but it's not approved for other treatments in Parkinson's disease. So those trials are underway. And if you wanted to know about CBD oil, you can type into clinicaltrials.gov cannabidiol, and you'll see that there's some trials in Colorado about the efficacy of cannabidiol. And this is a compendium, at least as of a bit ago, 2017, of the different studies that have been conducted using cannabis or cannabidiol on Parkinson's disease. So the largest study is 84 patients. They smoked it, and it says 46% of patients described some benefit, 31% reported improvement, and 4% reduced bradykinesia, and 14% reduction in dyskinesia. So this is kind of like a phase 2 study where it looks like it's effective in a relatively small number of patients. It's not a randomized trial, and it's now entering the randomized trials through the only center I saw was University of Colorado. So it's not something that we would say is FDA approved or has been proven to be effective at this time. It's being evaluated. So these are some people who helped me with my research, and I'm extremely thankful for all of the participants who have helped trying to come up with new treatments and biomarkers and strategies for Parkinson's disease. This is sort of not really on topic, but it's just my final slide, so I'll end there and I'll take questions.
Questions? Okay. Start here.
So I guess I'm curious about global research compared to what's being done here. Like, do we, studies that are done in Asia or, anywhere else in the world, like, do we communicate with them? Do we have like a partnership with them, and we know what they're doing, they know what we're doing, or is are the things that you've discussed today, are those more central to North America?
So some of the things I've discussed are being evaluated in other countries, and generally some of the European studies tend to be a little bit ahead of what's available in the United States. So we don't take their data as necessarily meaning that the agent will work here, and it usually is required to go through clinical trials here as well. But I don't think that there's like loads of other things out there that's not on this list, and some of them, Ambraxol is just in the UK. Many of these trials actually do have arms that are in Europe as well.
Another question?
I understand there has been some recent research with respect to using human tear fluid as a source of a biomarker. Is the case that alpha-synuclein is found in the tears?
I don't know.
This was a paper that was just published in July.
Uh-huh.
I think it was oligoramic forms.
Uh-huh.
Synuclein were found in human tear fluid, and they apparently an accurate quantitative decision could be reached about how much is in the person's system.
Uh-huh. Well, that sounds fascinating. I'll look it up.
Thank you.
Another question over here.
So my understanding is that there is nothing in clinical trials as far as human beings are concerned right now, correct?
There are a lot of things in clinical trials as far as human beings are concerned, and some of them are these things,
Okay.
and these things. So there are quite a few. There are quite a few going on.
There's something I was reading about. It's called MCC 950. Are you familiar with that?
I'm not. Can you tell me about it? Mm-hmm.
So she might be Googling just to see.
So it says it's an anti-inflammatory, and you can buy it, which I think is for laboratories. It inhibits inflammasomes. So, I don't know. I mean, I know some of these things, but for me to read about everything that's possibly out there, I don't have that at the tip of my fingers. I understand.
Yeah, so I think he's just saying it sounds like so far we have not had anything come out of hugely out of fruition to reverse or improve upon things other than maybe medication to try to help with symptom management.
Mm-hmm.
Okay.
Well, I mean, nobody knows exactly how many years down the line we're looking, because if, for example, that nilotinib or similar, they're called ABL or kinase inhibitors, if those end up working out, I mean, that could make a huge difference. And those are in clinical trials right now. But it is true that for Alzheimer's disease, there hasn't been a new treatment since 2000, because it just, again, and Alzheimer's is getting much, much more research money than Parkinson's disease is, and they still don't have a treatment for it. And the reason is the complexity, I think, unfortunately. But I'm hoping, I mean, I just don't think, we don't know when something is going to come through.
Under the managing of disease symptoms, is there anything particular that might help the orthostatic hypertension?
So there's a number of medications. There's Florinef. There's a number of already approved medications. Mm-hmm. And one of the most recent one is this Nothera, which is droxidopa. So it's it sort of makes the blood vessels in the body constrict to try to support the blood pressure. So Nothera is very expensive, but there's a number of other agents in that category, midodrine, Florinef, which have been are conventionally used and are available.
Yeah, he's been prescribed some midodrine, and we've had some varied, success with it. It works for a short period of time, and it can raise it for a short period of time, but we haven't figured out the sequence that would really do a lot of benefit for it.
So your other options are Florinef or Nothera, and there's an approval process and support system for using Nothera, so you could ask about that.
Yeah, he's got an appointment with somebody here now to see if there's something else that can work better, but okay.
Just a second.
Here, do you want to?
You were referring to the dopamine in the nuclei, and I just was questioning about Lewy body. You talked about the Lewy body nuclei a lot, and I wondered, there's a form of Parkinson's that's called Lewy body, but all Parkinson's is a Lewy body, necessarily, right?
I like this one because I can answer this one. So, Lewy body disease is a condition in which patients develop cognitive thinking, mental processing problems around the same time that they develop Parkinson's disease. And they might have other features such as hallucinations, delusions, kind of losing touch with reality a little bit. And sometimes they also have severe orthostatic hypotension. And we think that the pathology, if you were to look at the Lewy bodies in the brain in those patients with Lewy body disease, that the distribution is out in the cerebral cortex at the time when they're having those symptoms. And there might even be a variant where people get Lewy bodies in the cerebral cortex, not just moving up from the brainstem the way that they do with typical Parkinson's. And often the Lewy body disease is mixed with Alzheimer's disease. So they both have Lewy bodies, they both have these protein clumps, but the distribution in the Lewy body disease with the cognitive problems is different from the typical Parkinson's distribution. She's wondering if it's true that 90% of Parkinson's patients end up with Alzheimer's disease. We do think that there's a higher risk of Alzheimer's disease and Parkinson's disease and Parkinson's and Alzheimer's, probably because of these parts of the cellular machinery that have to clear those proteins. If they're not working right, they could result in the accumulation of the Alzheimer's protein or the Parkinson's protein. But I wouldn't say 90%. I'd say, a certain percentage. And the other thing is that many people develop Alzheimer's changes as we age, and they aren't necessarily 100% of the time correlated with symptoms. So some of the people who had those scans would have the protein in their brain on the scan, but they would be able to think and behave normally. So the protein marker is not inevitably, in all cases, mean that the person has dementia.
I have one back here. Can you see me okay?
Yeah. Mm-hmm.
You mentioned, I think, something to the effect of the olfactory system being a cause or a biomarker, bacteria from it or what have you. That's the nose, right?
Yes.
Could you explain a little bit what the theory is there?
So one place that Heiko Brock, when he is studying his cross-sections of the brain, one area that he reliably would see Lewy bodies, the Parkinson's inclusions, was in the part of the brain that the nose goes into. So the nose takes smell in, and it goes right into this track that comes right out kind of underneath or above the eye and carries smell into the brain. And that's called the olfactory bulb, and that's a place where they'll see these Lewy bodies very reliably early on in Parkinson's disease or even in that pre-Parkinson's. And that's what led to the theory that maybe something comes in through the gut and something has to come in through the olfactory system as well, and these have to get together and create inflammation in some way that produces the movement of the disease in the brain.
Do they have some idea of what's coming in through the nose? Is it something out there that we're breathing? Or
we don't know. It's not known. Virus, is bandied around, but I mean, there's a lot of things that could be a virus.
You talked about early diagnosis and a lot of the research being done on that. Is the effort there to start treatment early? And is the treatment with the current drugs, is the treatment to decrease the progression speed, or is it to start the treatment earlier and just deal with symptoms? And the second question related to this, is there a relationship between the lack of effectiveness of the medication the longer you're on the medication? So early diagnosis and starting treatment early may deal with some minor side effects, but would it decrease the effectiveness of the medication as the progression of the disease is there?
So the idea about early treatment and early detection is that by the time you detect Parkinson's, usually about only 30% of your original of those dopamine neurons are still present in the brain, because the brain is very much able to protect itself, so there's a lot of compensation. So at the time when Parkinson's disease is detected, we've lost 70% of those dopamine neurons. So the idea is if you could institute something to prevent the loss of neurons, it would be most effective if it could be applied as soon as possible. And that's been the rationale for all these therapies or all the desire to detect these diseases as early as possible. But it's true that we don't have a treatment that actually modifies that disease process at this time. So, it's not really necessarily useful. The treatments we have for Parkinson's disease don't lose effectiveness, but what does happen is that when you give levodopa, it has to be taken up it has to get into the brain through the gut, and then it has to get, and then it kind of bathes the brain, and then eventually some of it gets to where those dopamine neurons are, and the dopamine neurons have to take up that levodopa, the precursor, and they have to turn it into dopamine. So early on in the disease, when you have those 30% of your normal neurons, then they can kind of bolster themselves and get extra precursor, and they can release that dopamine, and it can last a long time because the cells are alive, so they can store it. So the doses last 8 hours, or some people they last 12 hours, or they may last 5, but anyway, they last a longer time. But then as you start to lose those neurons, ultimately there are not really any neurons left. Then when you give levodopa, the levodopa goes into the bloodstream. It is converted to dopamine in the brain, but it's converted by glial cells, and it's not converted and kept by dopamine neurons. So then the effective time of the dose is basically the half-life of the medication in the blood, which is a few hours, 2 hours. So the time that it's effective for gets shorter and shorter. And so we oscillate between having the medication effective, and then it goes off, and then it's effective, and then it goes off. And we also think that oscillation is what produces, in some patients, dyskinesia. So it doesn't lose effectiveness, but its satisfactory application becomes more difficult.
I guess I didn't pick up on whether or not the...
So you were describing what this little blue pill does? Cardopa. You're describing what that does. I wanted to know what that little blue pill does.
So there's two parts of the pill, right? There's the levodopa, that's the active part, and then there's the carbidopa. So the carbidopa, if I just give you levodopa, then your body will break down that levodopa into dopamine, and it goes to your kidneys, and it goes to all your other organs, and it causes high blood pressure, and it causes nausea, all these other problems. And it never gets into your brain. But if I give carbidopa, that prevents, there's an enzyme called dopa decarboxylase that's everywhere in your body, and it breaks down levodopa. So if I give you that carbidopa, that little part of it, then that enzyme can't be active. It can't break down the levodopa in the body, and then it goes more into the brain. So that's the reason for giving the carbidopa. So the pills you have are carbidopa, there's usually 25, and levodopa, that's 100 or 200. That's the active part. Yes?
Are you here in Madison involved in the nilotinib studies? And regardless, what is the schedule? They must almost be done with the phase 2 trials by now, right?
They're in phase 3. And actually, UW is going to be a center for one of these kinase inhibitors similar to nilotinib. I'm not sure if it's that one, but Kathleen Shannon is going to be the PI of that clinical trial.
Question over here. Everybody got to run.
Thank you for a wonderful presentation. I'm very intrigued by the gut interaction with the gut and the brain function, how that all works. So what do you think is making the connection? Is it something that we eat, or is it pathogen load, or how does the gut interact with the brain?
So one other thing that I didn't talk about was the microbiome. So one thing is that there's all these organisms that live in the gut and sort of have like a, I don't know what you call it, a consensual relationship with you. So they help you digest your food, and they're all in your stool. And so if we take a sample of the microbiome and we look at the DNA of those organisms, we can clump them into species. So a lot of studies have been done looking at the proportion of different species and showing that, for example, patients with Parkinson's disease have a different gut microbiome species than people who don't have Parkinson's disease. And even some of the patients with REM behavior disorder might have a different gut microbiome. So one of the theories that's been put out there is that maybe this imbalance in the microbiome is leading to some byproducts that are triggering something. But that's a theory.
Do you know much about the trials they're running in Israel?
When I went on to the clinical, when I went to the Michael J. Fox Foundation website, that trial is listed. I didn't read about it in detail.
And lastly, I know a person, he had a stem cell treatment done, specifically from a fetus that was 7 to 12 weeks. And they claimed it's effective because they use us fetuses that are 7 to 12 weeks.
Was that done in the U.S.?
No.
Mm-hmm.
In Ukraine.
So the United States stem cell trials, they were able to transplant the cells. They were able to show on PET scans that those cells survived. And the problem is that the cells didn't connect up with other circuits and pathways in the nervous system in a very physiologic way. So the patients got some benefit from for their movement, but also some of them got runaway dyskinesias with excessive movement that was going on all the time, even if they're not taking levodopa. So that was one of the downsides. And the other side is that the movement improvement was not necessarily any better than we get with deep brain stimulation. So I think that the desire to do the stem cell transplants got replaced with how effective deep brain stimulation was. I don't know. The trials were by Kurt Fried, which was Kurt Fried was in Colorado. He was one of the investigators back in it was when I was in medical school. So I don't know the exact age. I'd have to go read the paper. Yeah.
The question back there.
There are multiple trials showing that many different types of physical activity, Tai Chi, physical therapy, high-intensity training, are effective for treating the symptoms of Parkinson's disease and are can even improve or reduce the need for medication. Usually not completely get rid of it, but definitely because the brain is plastic and can adapt. And so it helps to encourage the brain to adapt to the loss of movement and compensate for some of the problems caused by Parkinson's disease. So it's not a cure, but there's a lot of evidence that it's helpful, and it's actually being heavily used in Alzheimer's disease too.
Questions? Any other questions?
What's the status of deep brain stimulation research currently? Is there anything being done in that regard besides medical treatment?
So one of the new things is that some of the new deep brain stimulators, the leads before that came down into the brain had 4 contacts, and you could program circuits to go between those contacts. Now they've even increased the number of, they're going to have directions. So each lead is, some of them will have directions, so you can actually aim the stimulation around a certain direction in the brain to shield other areas. So those leads are available now. What there is interest in is a closed loop system. So they've started to have this for epilepsy, which is that there'll be an implant in the brain that is able to detect that a seizure is starting, and then it's able to stimulate the brain to prevent that seizure from propagating. And with deep brain stimulation, they're trying to get some internally adjusting systems that might kind of tune themselves to the patient's, to improve the patient's movements, rather than having to go into a clinic, have the person adjust it, evaluate your movements, and then, do that again 2 weeks later.
That's
Dual
my knowledge
leads. They're always looking for targets for improving walking, because deep brain stimulation doesn't improve walking very well. So there have been some efforts to stimulate different areas. There's also a lot of interest in using deep brain stimulation for psychiatric disease and stimulating some of the frontal connections to improve depression. That's actually approved now for severe depression. We were talking about the other day, like dual leads.
Yeah, so there's different places in the brain that we can put the leads to have effect on different symptoms. And so I do think there's some research on placing, some leads in the globus pallidus versus the STN. And is there another area that I'm trying to remember the letters of it that might work better for Parkinson's? But I don't know that they've had any success yet, and it's been small trials. So from what I remember talking to Dr. Lake about. Mm-hmm. That's not very helpful. Sorry.
My father has Parkinson's with Lewy body, and I think the biggest thing for him right now, and me trying to take care of him as his son, and my mom trying to take care of him as a caregiver, is the depression, is the state of mind. Not even so much, the movement. He has tremors. He moves slowly. I find that the worst offender is really just kind of the depression, and sometimes the state of mind of being, I think for him, he feels like, well, what's the point? And, he does physical therapy and he likes that. And, but I'm wondering, we don't have him on any medication right now for depression. And I have depression as well. I've been on medications, and it seems like it's kind of hit or miss with those kind of medications. And I hear that sometimes with Lewy body, sometimes they can have negative side effects with people with Parkinson's and Lewy body dementia. So I'm just curious, are there any new techniques or medicines that people are taking right now, any breakthroughs in that that they found that can help alleviate some of those depressive symptoms, or lethargy, or feelings of apathy, I guess?
Mm-hmm. Well, so the main medications to stay away from in the Lewy body dementia are the neuroleptics. So the medications like Risperdal and olanzapine, and they're often used as adjunctive therapies for depression, but they're not exactly antidepressants per se. There's some pretty good trials of using venlafaxine in Parkinson's disease, but also a lot of the just regular antidepressants, serotonin reuptake inhibitors, are often effective. There is loss of serotonin in Parkinson's disease, and it might even be before the motor symptoms start, and so some patients really suffer from that and may benefit from antidepressants. The patients who are really, really refractory, electroconvulsive therapy has been used effectively for very refractory depression and Parkinson's disease. And obviously that's kind of, you'd want a really good psychiatrist to say that that's the only option, but that is one option that has worked when all else has failed.
Looks like we're done with questions. Thank you guys for coming out tonight.